on the access to care front. First, consider this conundrum. Although most Americans say they support universal coverage, political and legal obstacles have repeatedly stymied attempts to achieve it. Contemporary barriers include ERISA preemption of state initiatives, since lots of these initiatives require employers to cover their workers or to pay into public funds to subsidize insurance. There's also ideological resistance to publicly supported coverage as incompatible with personal responsibility. And there are, last but certainly not least, healthcare stakeholders' concerns about disruptions in cash flows upon which they've come to rely. Foremost among the likely disruptions is the shift from veiled cross-subsidies to visible means of financing care for the less well-off. Americans subsidize care for the medically indigent through a variety of mechanisms that few understand. These include extra payments from the Medicare Trust Fund to hospitals with large numbers of uninsured patients, as well as private insurance premiums set high enough to contribute to the cost of indigent care. Publicly sponsored coverage for the less well-off would supplant these cross-subsidies with a high-profile tax, an inviting political target. The prospect of these cross-subsidies' disappearance, moreover, alarms hospitals and clinics who fear that public funding for broader coverage won't suffice to replace this burdened hand. Now, consider some emergence-oriented strategies, and I want to start with what's been happening at the state level. States have seized the initiative on the health reform front with creative and bipartisan ideas about how they might expand coverage. From a conventional health reform perspective, the prospect of 50 different state systems is anathema. A single national system, whether it's market-oriented or government-administered, is essential to avoid Byzantine bureaucratic and legal complexity. But from an emergent systems vantage point, the state-by-state route is worth encouraging. Ideological and interest group gridlock at the federal level makes national reform difficult. State-by-state progress, meanwhile, could build momentum toward nationwide insistence on universal coverage, so long as high-visibility state initiatives are seen as successes worth propagating. Think Massachusetts. Similarities in design are likely to result from the propagation of successful state models along informal networks of influence, and these similarities would ease administrative burdens. And if large employers or health plans become sufficiently concerned about the balkanization of legal and regulatory requirements, they could press Congress and the White House for federalization of the emerging universal coverage system. They might well succeed, demonstrating the power of feedback mechanisms to transform health policy and law in circuitous fashion and locking in a national commitment to medical coverage for all. If state-level reform